Hello everyone, and welcome to the Henry Schein webinar series on COVID-19. I'm Dr. Gary Severance with Henry Schein. And we'll go right to Dr. Reznik to get a clinical update, but then we'll be back to answer some of the questions that you've posed over the last few weeks. Right now, let's go to Dr. Reznik.
Thank you, Gary, and it's great to be back to discuss some of the latest updates, the clinical updates that we've seen in association with COVID-19, as well as answering some of the questions that you have been coming up with. We want to make sure that we address what your needs are and share the latest information so you can provide the safest visit as always. So let's get started with what are some of the new things that we've seen. On the not such great news, that we've seen the number of cases that are rising in at least 40 states across the country. There are close to 4 million people in the United States who've been infected with the coronavirus, and at least 145,000 people of our country have passed. That is a lot of people, just so you know, and there's a lot of people with this virus. The country is now logging an average of like 66,000 new cases a day. There are states who are setting records on a daily basis, cities that are being impacted really hard. And so this is still phase one, and hopefully we're about halfway through this first phase. And then, of course, there's all these advancements as in vaccines and in therapeutics that are truly going to help us get back to what our normal will be. Another thing is that we probably are underestimating or undercounting, even though we test more than any other country in the world. We're probably underestimating the number of people who have been infected by this virus. It's between 2 and 13 times the approximate 4 million recorded cases that we've had, according to CDC's research. And if you look at blood samples from 10 geographic regions, including Washington State, Utah, South Florida, which has been devastated by this, and New York, found that New York City had the highest proportion of antibodies within the population. So if you have antibodies, you have definitely been exposed to this virus. So when they looked at New York City, 24% had antibodies, which is a significant number. And we know at the beginning of the U.S. pandemic that New York was hit very hard, very early. If you look at May and June data, it indicated that less than 3% of people from Missouri had antibodies, and a little bit over 3.5% from Philadelphia residents have them. So when we talk about this concept of herd immunity, where everyone will get the virus, everyone would develop antibodies, and we would be over with, that isn't going to look like it's going to work at this point. We believe that 60 to 70% of the population must contract the virus to achieve the so-called herd immunity. And this is based on other kinds of viruses that we have dealt with in the past. So it doesn't look like we're going to get herd immunity. It does look like there are a lot of people who have this disease who are going undiagnosed, and we have a lot of asymptomatic people who don't have symptoms of the virus but yet still can transmit. What about some good news? Well, this is a CDC report, absence of apparent transmission of SARS-CoV-2 from 2 hairstylists after exposure in a hair salon. So they had a universal masking practice in this program at Springfield, Missouri. Every one of the providers had to wear a mask. Every one of the patients had to wear a mask, which in our case is a little bit harder. But consistent and correct use of face coverings is recommended to reduce the spread. We know that. Amongst 140 or so clients exposed to 2 symptomatic. So these people actually had the disease and were symptomatic, these hairstylists. So the stylists were working. They were masked. The patients or their clients were masked. There were no symptomatic secondary cases reported amongst 67 clients tested for SARS-CoV-2. All were negative. So it really does show if we mask and we consistently mask, we might be able to get our hands on this. And I think it gives us an important lesson from the dental setting, which is in between patients, when we're not really working on patients, when we know we're going to have all of our PPE on, it is very important that we maintain masking on so we don't bring it into our practices and that we protect each other. This is just a time where we need to come together together and follow the best recommendations to ensure that we stay safe and healthy and that our families stay safe and healthy. This is just a graphic showing these two hairstylists who had symptomatic disease, who spent at least 15 minutes with about 140 clients. You can look that everyone wore face coverings. No clients were affected. This is huge news. So it does show that wearing a mask appropriately, not where your nose is exposed, not under your chin, not on your forehead, but wearing a mask is really a smart thing to do to protect you and your family, and something we should do in between our patients as well as when we have our PPE. Now, this is actually some new news that I'm going to spend a little bit of time going over because it is a change from previous recommendations that came from the CDC. They're basically showing that evidence support ending isolation and precautions for people with COVID-19 using a symptom-based strategy, and I'm going to explain that a little bit more. The following update is going to basically save some lab testing, and that's a big issue. As you know, we're having in the most impacted areas a significant amount of delay in getting a test, and even more problematic is getting your test results. In Atlanta, where we're having a bit of a mini spike, I guess we would say, getting your results back for non-surgical procedures is taking 7 to 8 days, and that's a really long time. So what can we do to eliminate some lab testing and also get people back into the system a little bit faster? So what they found when they did this study that was published this month from the CDC, they found that the concentrations of COVID-19 measured in the upper respiratory specimens declined after onset of symptoms. So you get your symptoms, you have a high viral load, and then all of a sudden the RNA starts going down. And you can see this was published by several sources from the U.S. and around the world. The likelihood of recovering replication-competent virus also declines after the onset of symptoms. For patients who have mild to moderate disease, and I'm going to explain the difference between mild, moderate, and severe disease, but for mild to moderate disease, replication-competent virus has not been recovered after 10 days following symptom onset. So, instead of the 14 days, instead of the 21 days, for people with mild to moderate disease, after they can actually come in after their symptoms are gone after 10 days. Recovery of replication-competent virus between 10 and 20 days after symptom onset has been documented in some persons with severe COVID-19. So we have this 10 to 20 days, so how do we differentiate? They looked at 88% of the specimens no longer yielded replication-competent virus after 10 days, and these are people with severe illness. So 88% did not have replication-competent virus. 95% of the specimens no longer yielded replication-competent virus after 15 days, which is why for people with severe disease, they have it out to possibly 20 days. A large contact tracing study demonstrated that high-risk household and hospital contacts did not develop infection after the exposure to a case patient starting 6 days or more after the patient's illness onset. Although replication-competent virus was not isolated 3 weeks after symptom onset, recovered patients can continue to have some RNA detected in their upper respiratory tract for up to 12 weeks. So you can do this PCR, you can find some RNA, but it's not able to replicate, so it really isn't able to be contagious. Investigation of 285 persistently positive people. So they had it, they kept on getting checked down the road, which included 126 people who had developed recurrent symptoms. Remember, we're trying to go away from symptom-based, found no secondary infections amongst almost 800 contacts attributable to contact with these case patients. So efforts to isolate replication-competent virus from 108 of these patients were unsuccessful. So we have people who show up with symptoms, but is it reinfection? We really don't think that is the case, that the symptoms don't clear up quite as fast as the inability of the virus to replicate. Specimens from patients who recovered from initial COVID-19 illness and subsequently developed new symptoms and retested positive by PCR did not have replication-competent virus. So like I just mentioned, you can find some virus using PCR, but you can't find virus that will be able to replicate. The risk of reinfection may be lower in the first 3 months after initial infection. This is based on antibodies. Antibodies are one of our ways of protecting ourselves, based on limited evidence from other family members of the beta coronavirus genus. Currently, 6 months after the emergence of SARS-CoV-2, there have been no confirmed cases of reinfection. I think that's very important too, and it sort of helps us look at where we are with this vaccine and antibodies. It sort of says, well, we know that you don't have replication, competent virus after 10 to 20 days, depending on the severity of your illness. We know there's been antibodies, no reinfections after 3 months, so we know antibodies are involved. And currently, 6 months after the emergence, there have been no confirmed cases of reinfection. So antibodies are playing a role, and it gives us an idea as to how long these antibodies from a vaccine will work. So the assessment. Available data indicate that persons with mild to moderate COVID-19 remain infectious no longer than 10 days after symptom onset. It used to be 14. Persons with more severe to critical illness or severe immunocompromised patients likely remain infectious no longer than 20 days. So for those severe patients, people who have been hospitalized, people in ICUs, people who won't be coming to see us for the most part within 20 days, they remain infectious no longer than 20 days. Reinfection with SARS-CoV-2 has not been definitively confirmed in any recovered patients per date. And, we've had this going on since December. We're now in July. So apparently, we have this pretty well in hand that we know that reinfection isn't going to be common, at least within the first 6 months. So the recommendations for the duration of isolation and precautions, and this is for us. For most persons with COVID-19 illness, isolation precautions can generally be discontinued 10 days. I keep on repeating it, 10 days after symptom onset. So you develop your symptoms, you get your test, hopefully you're in a place where you can get your test results back. 10 days after symptom onset, you can possibly stop your isolation precautions. Or resolution of fever for 24 hours without using fever-reducing medications. Remember, now, not everybody gets a fever, although it's the most common sign. It used to be 72 hours of resolution of the fever without any kind of fever-reducing medications. That now has changed to 24 hours. So it really does limit the amount of time that people have to stay isolated, etc. For persons who never develop symptoms, isolation and other precautions can be discontinued after 10 days after the date of their first positive PCR. So that is important. If you never develop symptoms, and about 40% of the people we deal with are not going to have symptoms, after 10 days of testing positive, they can come back. And that is whether it's someone you work with. Of course, check on your legal side on that and on OSHA guidelines. But according to the CDC, if they just test positive, had no symptoms, 10 days following that first initial test. So I said I'd go over what the differences in the disease states were. For mild illness, individuals have any of the various signs and symptoms of COVID-19, so fever, cough, shortness of breath, being tired, headache, muscle pain. A lot of people are coming up with a loss of smell and taste. Now remember, that is very common with other viral diseases as well. Without shortness of breath, so you don't have any pulmonary involvement at this point, and abnormal chest imaging, that is mild disease. Moderate illness, individuals have evidence of lower respiratory disease by clinical assessment or imaging, so you can find pulmonary involvement. And the O2 saturation, so your pulse ox is greater than or equal to 94% on room air temperature at sea level. So 94% for pulse oxygen is somewhat low. We want to be 98 to 100. If you're on full oxygen, and it should be 100, I get mine checked when I have some procedures done because of my back. 98 to 100 is a standard. But moderate illness with the pulse ox will be greater or equal to 94% at room air at sea level. Severe illness, I think we've heard a lot about severe illness because they report a lot of that on the news. Individuals who have respiratory frequency of greater than 30 breaths per minute, they're not able to breathe, they have shortness of breath. Their pulse ox is below 94% on room air at sea level, or for patients with chronic hypoxia, a decrease from baseline of greater than 3%. So if you have people already on oxygen who have a low pulse ox, a 3% reduction. Critical illness are people who have respiratory failure, septic shock, and or multiple organ dysfunction. You will not be seeing these patients unless you're in a hospital practice, and even in a hospital practice like I have, I would not be seeing a critical patient at this point. We would figure out a way to deal with whatever the concern is. So I just wanted to go over a little bit of that. I also wanted to go over the role of PCR testing, but before I do that, I want to talk about this asymptomatic issue that we're seeing, that so many people, about 40% of the people who do test positive never have symptoms. It reminds me back to the earlier days of the what we now know as the HIV pandemic or the AIDS pandemic. And what we developed were standard precautions, initially known as universal precautions. And it was based on the fact that we made the assumption, because we couldn't look at somebody and tell that you had an infectious disease, that everybody had a bloodborne pathogen. We started gloving, we started we started wearing masks, we started doing PPE long before most of our medical colleagues did. But we did treat everybody the same, and we treated them as if they all had a bloodborne pathogen. Until we have a vaccine, or until we have some point of care testing, which I'm very much looking forward to and would love to discuss at some point, because we have point of care HIV testing we've been using for years at this point, and that's a much more stigmatized disease. But until we know, we have to treat all of our patients as if they have COVID-19. So everybody gets treated the same. We wear masks in between patients. We put on all of our garb. It doesn't matter if it's someone who is 11-year-old or if it's someone who is 41 years old. I think it's for the safety of our patients, for the safety of our staff, ourselves, and our families. So I think it's an important message to convey. So what about this role of PCR testing to discontinue isolation precautions? Remember, when I first started, we talked about the difference in dates, 10 days for mild to moderate disease, or 10 days post your first positive PCR, up to 20 days for severe, moderate, severe illness. So what is the role of PCR testing? Because we know that people have this virus that can be detected, but it doesn't replicate. So for persons who are severely immunocompromised, a test-based strategy could be considered in consultation with infectious disease experts. I am blessed to work with infectious disease department at Emory and at Grady. I think it's important that you try to make relations with someone who has infectious disease expertise. You could look at different kinds of providers, Ryan White providers, ID specialists that are all hospitals. You might be people that are friends that you know in your neighborhoods, but it's really sort of helpful to have someone to guide you through this. But for all other people, a test-based strategy is no longer recommended, except to discontinue isolation precautions earlier than would occur under the strategy I previously talked about. So if you want to get somebody back sooner than 20 days, you might want to do this. But basically, they have eliminated it. For persons previously diagnosed with symptomatic COVID-19 who remain asymptomatic after recovery, retesting is not recommended within 3 months after the date of symptom onset for the initial COVID-19 infection. That was a past recommendation. That is no longer a recommendation. In addition, quarantine is not recommended in the event of close contact with an infected person after those days we talked about, after the 10 days, after the 20 days. For persons who never develop symptoms, we just talked about these asymptomatic people, the date of their first positive test, their first positive PCR test for SARS-CoV-2 RNA should be used in place of the date of symptom onset. So the first positive test, 10 days later. So there are some footnotes I'd like to go over. These studies were used to inform the guidance did not clearly define severely immunocompromised. And I work with that patient population, or at least a portion of that patient population. For the purposes of this guidance, CDC used the following definition that was created to more generally address healthcare professionals' occupational exposures. Some conditions, such as being on chemotherapy for cancer, and remember, 5 to 7 days after a lot of chemotherapy, the neutrophil count drops out and people are more susceptible for getting infections. Untreated HIV infection with a CD4 T lymphocyte count less than 200. We call that stage 3 HIV or AIDS. It's an AIDS defining condition or illness. So this is someone with HIV not being treated, not controlled with a CD4 count that's low, so they have an AIDS condition. Combined primary immunodeficiency disorder and the receipt of steroids greater than 20 milligrams a day for more than 14 days. And we've always had to address that in dentistry. They may cause a higher degree of immunocompromise and require actions such as lengthening the duration of work restrictions. And so if you want to look at it, work restrictions or patient restrictions, if you have somebody that's a chemotherapeutic patient, if you have somebody who is an uncontrolled HIV patient, if you have somebody who is on steroid use greater than 20 milligrams for a period of time, a medical consult is really needed for when that person should come back to work and when you could see that patient. So I think it's really important that you have great established relations with a medical person who has this kind of knowledge. So infectious disease docs are great at this. Even some Ryan White docs, HIV docs are great at this. They understand these things. Your oncology colleagues are great at this. They know these things. So it's really a time for medical dental integration for us to properly manage the patient population. Other factors such as advanced age, diabetes, especially uncontrolled diabetes, or end-stage renal disease may pose a much lower degree of immunocompromise and not clearly affect occupational health actions to prevent disease transmission. Ultimately, the degree of immunocompromise is determined by the treating provider, and preventive actions are tailored to each individual. So we have some general information I've gone over, but everybody should be treated as an individual. So summarizing all of that I just went over, some of it which was in the weeds, and I do understand that. For mild to moderate illness, isolation for 10 days. For severe illness, hospitalization, isolation for 20 days. Retesting within 3 months is not necessary unless there's a recurrence of symptoms. So there has been significant changes, and I just wanted to make you aware of those changes. If you've been watching the news lately, you know that we've had this testing crunch, which I also previously mentioned, that we're running out of swabs, we're having issues with reagents, states that are hot spots, and regretfully, these are some of the biggest states in our country, Florida, Texas, California. It's like having 3 New Yorks at once, all taking place at one time. So getting our hands on some of these supplies and getting our results have become a little bit more difficult. So what they're talking about is pooling some samples. So the FDA reissued an emergency use authorization to one of the companies, Quest Diagnostics, for use of pooled samples containing up to 4 individual swabs. If they're all negative, then that's fine. You don't need to retest it. So you've done one test to find that 4 people are negative. Sample pooling is an important public health tool because, well, we're running out of resources, and more people can be tested quickly using fewer of those resources. Sample pooling does this by allowing multiple people, in this case 4 individuals, to be tested at once. If someone is a positive, then all 4 would. If there is a positive that comes out of that pool sample, then you would test all 4. But it really does eliminate a lot of people who would be negative, who are negative, and it saves some of our resources, which are very valuable at this point. Just like our gowns and our PPE and how we use them, it's very valuable that we use them to the utmost, that we take advantage of our limited supply. If a pool is positive, I mentioned, that means 1 or more people has been infected, so those samples are then tested. So the next thing that we're going to do is I'm going to turn it back to Gary. We're going to do a little bit interactive conversation based on getting some of the questions that have come through answered. And so this will be a time for Gary and I, or Dr. Severance and I both, to share some of our knowledge and some of the information that's been out there. So Gary, let's get started with trying to answer some of these questions and answers.
Reznik, for your clinical update each week. And as you mentioned, we're going to answer some of the questions we've been getting over the last few weeks on our webinars. We've got a very robust audience with a lot of information. So if I can start with the first one, what is the difference between an N95 respirator and a KN95 respirator?
So the difference between an N95 and a KN95 is that the N95 is certified by NIOSH. It's certified by a U.S. agency, which is part of the CDC, and it normally has two straps that go around it, not a loop thing that fits around your ear. So you'll have a strap that will come above your ears and like this. So I'm going to show you an example. This is an N95. It'll have all the right markings on it. The difference between this and a KN95, honestly, is that the KN95 is produced in China. And they normally don't have the bow straps. They normally will have ear loops. There are some that have been approved for use in the United States. It's very important when you look at your KN95s that you make sure you go to the FDA website to make sure that they are legitimate. But if they are legitimate, they have the same efficacy as long as you get that tight seal around your face as would be an N95.
Next one is, can you explain the process of changing disposable gowns in between patients, for example, for hygiene appointments?
So this is a bit of a two question at once. If you're just doing exams, we have a limited amount of our disposable gowns. We have a limited amount of our lab coats that are laundered. And so we're trying to make the best use of it without putting anyone at risk. So if you're just doing hygiene exams, we're wearing a coat and we're not changing the coat in between patients. If we're doing any kind of procedure that would soil the coat or soil the disposable gown, then we change it in between patients. A lot of this actually is basically based on common sense. So if you're just doing exams, you're not creating any kind of soil on your coat or on your disposable gown, you can wear them just in between exams. If you're performing an aerosolized generating procedure, then you would want to change your gown between each patient. It's very, very important to make sure that you disinfect your shields, that you properly doff and don like we've talked about before.
Follow up to that, if you're performing non-aerosol generating procedures, do you need to change the disposable gown in between patients?
Again, if you're performing non-aerosolized procedures and say you're adjusting a partial or denture, let's just use that as an example, and you have a way of containing the particulate matter that you're adjusting. So whether it's using a simple headrest cover or a more fancy device or using one of the extra oral aerosol evacuators, if something gets on your coat, discard it, change.
Another one about gowns. Can disposable gowns be put in regular trash or is it considered medical waste? And what about those that are laundered?
So a disposable gown, as you remove it, remember we talked about the different ways of doffing, really can just go into your regular trash in the room, in the dental operatory. For a launder gown, though, they have to be placed in a fluid-resistant bag labeled with a biohazard signal. You know, we've really taken that to heart with our bloodborne pathogens on how we move objects from a dental operatory into our infection control sterilization areas. It's the same thing here. If we're doing launder, please make sure you put them in a fluid-resistant bag and that they're labeled as biohazard, and that'll take care of it for you.
Sticking with gowns, can you spray gowns with a disinfectant and reuse them?
I'm unaware of any way that you can actually disinfect a soiled gown. A soiled gown needs to be tossed. If it's like we discussed, you're not doing aerosol generating procedures, you're just doing exams or you're whatever, then it doesn't need to be tossed, but please don't try to disinfect them and don't spray your coats. There might be some technology that's going to be coming up about fogging that might be able to make them reusable, but at this point, don't. That would be my answer.
The question is, we are having to reuse our N95 respirators and have been disinfecting them with a disinfectant. Any advice, because they continue to smell, any advice on how to disinfect the masks or respirators?
For people having to reuse N95 masks, and that is a lot of us, honestly. They've been, some people want to use different kinds of disinfecting techniques. So advice on how to disinfect techniques, Gary has actually been kind enough to supply a link to watch on how to sanitize N95 masks for use based on an NIH study. There's also work on Medscape. Please don't soak your coats or spray your coats with a disinfectant, hoping that they'll be clean in a day or two. Exposing contaminated N95 respirators to vaporized hydrogen peroxide or UV light does appear to eliminate SARS-CoV-2 from material and preserve the integrity of mask fit for up to 3 uses. So that's what the NIH study had talked about. We actually went over that before. Dry heat was also found to eliminate the virus on the mask and was effective for 2 uses. And then Robert Fisher, a PhD from the National Institute of Allergy and Infectious Diseases in Montana, and colleagues posted these findings, and it hasn't quite been published yet. But again, please don't spray your mask. If you get your masks wet, they lose function. So it's really important to keep your N95s dry. So one of the things that people do is they would wear a surgical mask over the N95 as a way of protecting, and then having a face shield over that. So if you're just wearing goggles for eye protection and an N95, please try to play the highest level mask. Remember, there's up to level 1, 2, and 3. The higher the level, the more fluid resistant it is. So wear a level 3 mask over the N95 to protect it, as opposed to trying to spray it with something. I honestly don't. If they get wet, they lose function.
Another one, we are a surgical center and we use blankets in post-surgery for patients. Do we have to wash, or can we reuse those blankets in between patients?
We actually, I work in a comprehensive outpatient program for people with HIV disease, some of which, the majority are well controlled, but we do have those that aren't well controlled. We also perform outpatient chemotherapy at our program. The blankets that we use for our patients are 1 patient per. They need to be washed in between each patient or laundered in between each patient. If you use the service, again, biohazard bag, place them in the non-leaking fluid-resistant bag and get them serviced. But there's really no quicker way that I'm aware of to disinfect these blankets. I think we just need to increase our inventory on blankets, and to my knowledge, there aren't a shortage there.
Mouth rinses do you recommend for pre-procedural rinses?
We've been talking about using chlorhexidine for antimicrobial reduction before oral surgery for quite some time. There are some evidence. Now, the CDC has no guidelines. The ADA at one point recommended 1.5% hydrogen peroxide. Peroxyl is a product that already comes in that percent, and that hold in the mouth for 30 seconds. We use a saliva ejector. We don't spit anymore in the oral health center. If you're a fan of sports, you'll know that baseball is coming back, or baseball is back now. And it's going to be sort of odd seeing fake fans in the stands, but we will have sports back. No spitting tobacco, no spitting sunflower seeds, no spitting in baseball. And if you've watched baseball like I have for most of my life, that's been one of the biggest issues, that they spit all the time. Baseball is not spitting. Oral health centers, we're not spitting any longer. There also is some reduced povidone iodine that has shown to be a little bit also effective, but quicker. There's some studies that are in process. There's some papers that have been published. Presently, I'm using the Peroxyl. I'm looking at using povidone iodine too as another way of reducing the salivary microbial count, the viral count. But then again, there are other things that we can use. These extra oral aerosol protectors, using rubber dams whenever possible when we're using aerosol generating procedures. So we do need to have more research on these pre-procedural rinses. We need to see what the viral loads are before and then measure the viral loads 15, 30, 45 hours, so forth down the road. There is no recommendation at this point to re-rinse or do it over again if the patient procedure is longer than an hour.
Here's one I can answer. I thought UV lights need minimum exposure time to destroy the virus. Placing them in vents and furnaces doesn't allow enough time to kill. What's your opinion? And that's very true. Just about every pathogen has a different method or timing needed with UV light, UVC light. It's really based on time, the distance, and the intensity. And you can imagine if you put these in HVAC systems or even in these air purifiers, just UVC light, the airflow alone is pretty fast through there. So most of these air purifiers use multiple systems or consequences, meaning HEPA filters, MERV filters, and at the very end, possibly UVC. So it's kind of as a last resort many times. And it needs to be recycled. So the UVC can be used and the air coming in and in can get disinfected. But most importantly, I think most are combining UVC with titanium dioxide rods. Then you get something of an oxidation, which actually can kill the viruses, photocatalytic oxidation. But still remember that air coming out is not 100% of any of these systems. However, there is one system that has a single pass kill rate. That's the Eradicate system. And that is every time air goes through, it's essentially 99.999%. And that's because they have a reaction chamber, something that really uses photocatalytic oxidation in a large dose of the UVC light along with the titanium dioxide rods. And so they claim then that they continually clean the air in a single pass, whereas other purifiers or the HVAC systems may get some through it, and eventually in a time capsule or within 60 minutes, sometimes they can claim getting all of the bacteria filtered out or a majority of the filtered. But the short answer to your question is, yeah, having moving air going across just UVC, it takes longer exposure to all time most times. Should we require patients to be tested for COVID before performing AGP or aerosol generating procedures?
That's really an excellent question. All of these questions have actually been excellent questions. My mother-in-law actually had to see ENT at Emory. Before she was able to be seen, she had to have a COVID test. Now, we actually did this through Grady, through my facility, and so she was able to get the test and get results back and have the procedure performed. And so they did require testing before. I don't know that we're in that position at this point. I think we're more in the position, as I mentioned earlier, until we have great point of care testing, which I hope happens soon, because that'll really give us a definitive answer. Does the person have SARS-CoV-2 at that point in time? So until then, we have to treat every patient as if they are carrying COVID-19. I don't think we want to have any of those scenes. I'm sure you've seen that little TikTok video of the patient going a little bit out of control because we wanted to take a temperature. So at this point, I think we'll just stick with until the point of care testing is available, and I'm hoping that's available soon. We'll assume that all of our patients do have COVID-19 and perform the skill set that we know to help them stay and maintain health.
If a patient tested positive and has been quarantined for the appropriate number of days, when is it advisable to see them? And when they do come in, are there any special instructions?
So we've spent a great deal of time this morning talking about if someone has a positive PCR test and no symptoms, it's 10 days following that positive PCR test that they can be seen. If they have mild to moderate disease, 24 hours without temperature, if they are not taking any fever-reducing medications. It could be if they had severe disease up to 20 days, depending on the extent of disease. If they've tested positive, they've had the disease, remember it's 10 days since the last symptom. So there are some specific guidelines that we do have, but it's important to stay up with the material as it changes. Remember, this is new, it's rapidly changing, it's hitting different parts of the country at different times, and so there are instructions that we need to do. If this person does come in 2 weeks, they had a positive PCR 10 days before, they come in 2 weeks later, just like every other patient that we will be treating, we will assume that they have active COVID-19 and take all of our normal precautions.
If a patient tested positive and it's been 2 months since they had symptoms, do you recommend they test negative before coming in?
We covered that today and during today's call. And these post-follow-up testing are not really needed because even if it shows up positive, the virus that you're seeing doesn't replicate. And if it doesn't replicate, it's not contagious. And so literally having someone retest 2 months later is not going to be a benefit. It might come back positive based on some pieces of the virus that are not able to replicate. So no, I would not recommend someone get tested to come in and see you if they've been positive. And remember, people tend to have, if they've been positive, tend to have antibodies at least for 3 months, hopefully for longer, which would actually offer a level of protection. So they don't need to be tested. If anything, they're probably safer than any other patient that you've treated because you know they've had it, they've been through it, and you know that they've probably created some antibodies.
Employee goes on vacation, are they required to get a COVID test before returning to work? And are they required to quarantine?
So I have staff that go on vacation. I just had one today that came back from vacation looking well rested and happy and thrilled to be back. We do not recommend that we do a COVID test on someone who's gone out on vacation. What we do is we screen every staff member, we screen every patient for symptoms and some questions when they come in to work. So when I come in every day, I'm screened for fever and I'm asked, do I have shortness of breath, a cough that's come up, or any of the other symptoms. That's when I come to work. When our patients come to work, they're screened on entry to the building, and then they're once again screened when they come to the clinic. So testing really isn't necessary for a staff person. We're just going to go on symptoms. But remember, they need to stay masked when they're not, just like everybody else in your office, when you're not seeing patients unless you're in a private office by yourself, because you don't know where they've been. You could have asymptomatic disease, and they're not going to show up positive on temperature and things of that sort. So they don't need to be quarantined. Just remember that we do all of our PPE when treating patients, and in between patients, we keep a mask on just to protect the rest of our team.
What is the protocol if an employee tests positive for COVID-19?
So luckily at this point, I have not had any of my employees test positive for COVID-19, but members of our program staff in the building have tested positive in the past. Again, contacting an infectious disease expert, doing a medical consultation. This is one of the times I think it's very important that you have good contacts with them. But remember, if it's mild to moderate disease, 10 days afterwards, they're fine. Moderate to severe, 20 days, they're fine. But then again, I honestly think it's the medical dental integration which is really going to help us. So remember, we're not so much basing it as much on improvement of symptoms because the cough can last for a period of time. The main symptom we look after is the temperature, and now that's 24 hours. And so literally we've gone away from test-based strategy. It's more of just on symptom, a little bit of symptom strategy, and then the days and the period after a detectable fever. So hopefully that will help you. But again, medical dental consultation and coordination really does help the best outcomes for our patients. If we're looking at oral systemic connection, we have to have dental medical communication to make that really work. As always, it's been a pleasure joining you with these clinical updates. Please don't ever hesitate to ask us any further questions. I'm going to turn it back to Dr. Severance.
Thank you for being with us today. If you have any comments, questions, or topics for future episodes, please let us know by emailing us at webinars@henryschein.com. And of course, please subscribe to our YouTube page by clicking the subscribe button below. Until we see you again, stay safe and stay informed.